From a laboratory point of view, it's actually exactly the same. So we still have the same laboratory, we're using the same equipment, the same test, but instead of taking the sputum that comes from the back of the throat and the nose, we're just going to test saliva. It makes some sense if you think about it. The sputum that comes up and we cough it up, does it infect our saliva too, contaminate it? So if we can get the saliva sample, it's much more simple for everyone. We need a certain amount of saliva. We're still trying to work out exactly what the quantity is. I think I'm going to ask for more rather than less. And it is hard to salivate on command, as all of us know when we wake up with a dry mouth in the morning.
So under what circumstances will these saliva tests be used? For example, we already know that there's a difference between when diagnostic and screening tests are used.
So our aim at the moment is to test to see how accurate the test is on saliva as it is on the others. So we're currently undergoing those tests in the laboratory at the moment. It looks like how we store the saliva will have an impact. So if you freeze it or you cool it down, you lose some sensitivity. But if you take fresh saliva for up to about 12 hours at room temperature, it's okay. And so the aim is, once we know that the saliva works just as well as the nasopharyngeal swabs, then what we'll be able to do is utilize it as an alternative. Now the alternative is for screening purposes. So when you're talking about, and as government has said, teachers, our health and social care staff, and we know that we also screen a large number of other employers. We've had scenarios with the bus company, for example. All those would go through this process, and particularly if you've got children being routinely screened, then we can do them. However, at the moment, if you're symptomatic, then we think it's probably still wise to use the nasopharyngeal because we want the higher level of accuracy. This is still very emergent at the moment. We're still developing the protocols to make this happen, and we don't even know actually whether people will follow the instructions we give them. So we have to go through field testing. I think it will take 2 or 3 weeks before we're really ready.
And in terms of that process, GBC understands that samples of saliva from COVID-positive people are being taken, perhaps to validate the test?
Yeah, I've got people running around at the moment getting swabs and then asking people to fill a sputum pot. And we have to test the two. We've got to see what the machine says on the nasopharyngeal, and then we've got to test it on equivalent saliva to see if there's variation or difference, and that's called validation. And then sometimes we throw in a wobbly to see if it detects a difference, and it should do. That gives us assurance that we're measuring the right thing, it's safe to do, and it's appropriate to do.
You've mentioned the concerns you have over people following instructions. So will this be a test where people provide the samples at home instead of going to be swabbed by medical professionals?
Yes, I think that's a great advantage of saliva testing. Most of us know that, well, most of us can spit. It's more difficult with children, trying to stop them spitting sometimes. And if people are able to do it at home, what I don't know at the moment is whether we do a collection system, we drop or we pick it up at a particular point or not. We're going to have to trial that out. There's no way I can go out in the world and say, you've done it before, tell us how you did it. There has been some trials at Southampton University, and we are borrowing some of their information. But this actually puts us at the cutting edge of most thinking. And I do want people to realise that in Gibraltar, we've put ourselves right at the forefront of a lot of developments.
With these samples being taken at home, how can the GHA ensure that the samples correspond to the right people?
Yeah, so that's one of the things I've got to work out. How can we can't just put something on a pot and say, scribble your name, because we won't be able to read it. So we're going to have to issue labelling beforehand, so we're absolutely sure we get what we want. Of course, if people want to cheat, then they will cheat. They'll find a way around it. But you know, the bottom line of testing, the bottom line of screening is all about protecting all of us.
The saliva test is also being piloted in the UK. Where is Gibraltar in relation to that process?
So we're using the learning that they've done in a trial, as I say, in the University of Southampton, and we're again able to borrow experience. Dr Nick Cortes has been participating in that. He's always been a prominent person in our screening and laboratory services here, and again through his good offices we've been able to access that information.
The government has announced an increase in swabbing, so is this part of the reason for the saliva test, to make it more cost effective and to reduce reliance on swabs?
Yeah, well, the bottom line is that Gibraltar in many ways is not quite unique but fairly rare in that we aren't able to control our borders. And that means we get 15 to 20,000 people every day coming in that could be carrying the virus. The only way we can address that is to have heightened surveillance, shine a flashlight in the darkened room to find out where it is. So we increase our rate of swabbing, we increase our rate of testing. If we make it easier for people to give us samples, then we can do it more rapidly and quicker. It can also change some of the dynamics about when we collect the samples. I know a lot of people get vexed because we can only phone them up late in the evening, because that's when our laboratory is reporting on the tests. If we can get the test done earlier, that will mean that they'll be phoned earlier as well.
Is it also the case that this will be safer for the medical professionals carrying out the test?
Yes, of course. At the moment, people have to wear PPE and stick a swab in someone's throat who might be infectious, and we have a duty of care to protect healthcare people. About a quarter of all our cases at the moment are in healthcare professionals. So if you're spitting into a pot at home and you're sealing it and then you were putting it into a plastic bag, then clearly the exposure is much less.
And in terms of the turnaround time on these tests, how do they compare to the other screening tests that we have at the moment?
So it's exactly the same technique as we're using. We generally can do analysis in about 4 hours, 4 to 6 hours. We don't quote 4 to 6 hours because obviously we have to get the samples back to the lab and we have to verify the tests. But in the actual process, laboratory process, it's only 4 hours. It will not be any different. And again, we've been ahead of the game in terms of using direct lamp, which is a technology again introduced through innovation.
You've said this will be rolled out in a few weeks' time. When the program is in place, how many tests will be able to be done per day?
Well, we're aiming for about 1,000. One of the things I want to be able to do is have some surveillance of our population as a routine. So we want to do a routine random sample of the whole population in senior school and above. And again, I think we'll be asking for some consent that we actually do randomly select people above the age of 11 in all settings, and that means that when we know there is an increase, we can target that population and do the appropriate protections for everybody. And I think that's 1,000 a day.